Good evening and welcome to Doctors on Call. I'm Dr. Ann Stephen, a pediatrician and the Chief Medical Officer in the East with Essentia Health, and I am your host for our program tonight on lower extremity, knee, foot, and hip problems. Our panelists this week include Dr. Brad Edgerton, an orthopedic surgeon with Essentia Health, Dr. Heather Grothe, an orthopedic and sports medicine physician at Essentia Health, and Dr. Katherine Schnell, a foot and ankle surgeon with Orthopaedic Associates of Duluth. Our medical students answering phones tonight are all from Minnesota. Nisa Grina of Hutchinson, Rachel Hoyer from Lester Prairie, and Brandy Bolig from Sartell. The success of the program depends on you, the viewer, so please call in your questions and we'll do our best to answer them. The telephone numbers are found at the bottom of your screen. And now, on to tonight's program. I'd like to start just by asking each one of you to tell me a little bit, or tell the viewers a little bit about your practice and how long you've been practicing in Duluth. Would you like to start? Dr. Schnell.
Yeah, so I'm Dr. Katherine Schnell. I'm with Orthopaedic Associates. Actually just recently started in July. I specialize in foot and ankle surgery, so specifically podiatry. So I'm focusing mainly on the foot and ankle, and my background and training is mainly on reconstructive surgery and arthroscopy techniques.
Very interesting. So you do quite a bit of surgery?
Yes, yep, absolutely.
Dr. Grothe?
I'm Dr. Heather Grothe. I'm at Essentia Health Orthopedics. I work in the orthopedics and sports medicine department. I treat predominantly non-surgical musculoskeletal conditions. I treat a broad range. We see everything from knee arthritis to fractures to acute sports injuries. I also do a lot of musculoskeletal ultrasound. So we do a lot of diagnostic ultrasound as well as interventional procedures. I've been in Duluth for almost 3 years.
So in addition to x-rays and MRIs, you're able to use ultrasound to see what the problem is for the patient. That's
absolutely, it's a great modality.
Yep. Dr. Edgerton.
Yeah, I'm Brad Edgerton. I'm an orthopedic surgeon at Essentia Health, one of Dr. Grothe's partners. My specialty is in artificial joint replacement of the hip and knee.
Okay. Okay, so you also do quite a bit of surgery.
A lot of surgery. We have a very large joint replacement program. We do over 1,000 joint replacements a year at Essentia.
And how long have you been practicing in Duluth?
I've been here 24 years.
Okay, all right. Well, let's start with Dr. Katherine Schnell. What would be a common complaint for a patient to come into your office that you would maybe end up doing surgery on them?
Yeah, so I guess probably the most common thing that people come in and asking about is just the basic bunion. There's a couple different types of bunions, and the surgery kind of depends based on the physical exam, what you're going to see on the x-rays. So those are kind of key components when we start talking about different surgical options. Conservative treatments, and I always tell patients to kind of start with some type of over-the-counter orthotic as well as wider shoes. We kind of talk about buying different types of shoes as well. And then there's different types of surgeries, including osteotomies or cuts in the bone versus just fusions of joints, and depends on different types of bunions that you might have.
About how long do you tell a patient it's going to take to recover from bunion surgery?
Yeah, so usually it's about 6 weeks. Sometimes it's completely non-weight bearing, so staying off your feet for at least 6 weeks. But I always tell patients that to give themselves at least a year afterwards, and kind of what you're stuck with after a year is kind of what you're left with, and that's kind of the final outcome of surgery.
You said if you're after a year, that's what you're stuck with. Okay,
yep, you got it.
Good to know. Good to know. Dr. Grothe, in your office, what do you most find that you're using the ultrasound for to diagnose which type of conditions?
So ultrasound is a really great modality to look at superficial soft tissue structures. So we can see tendons, nerves, ligaments in quite a bit of detail. So one of the things that we look at frequently, for example, rotator cuff injuries. So we can use ultrasound to see whether or not there's a tear of that rotator cuff. And the advantage of ultrasound is that it's dynamic, so it's in real time. And if the patient has pain in a particular area, we can see what's underneath that. We can see the structure beneath that. In addition, we can move the joint. So we can rotate, lift, we can see if it's impinging. It's also a great modality because there's no radiation. In addition, for somebody who has a pacemaker and not able to undergo an MRI, it's a wonderful modality that we can use. So,
thank you, thank you. I've been handed a few questions, and I think the first one I will direct to you, Dr. Edgerton, because it relates to a surgical implant. This question is from Margaret in Hermantown, and she says, has anyone heard of synthetic knee implants, and how are they working out?
Well, that's a pretty broad term, synthetic knee implant. We do joint replacements commonly in the
Yeah.
knee,
Mm-hmm.
and that's synthetic. I have an example here. This is an example of a knee replacement, and I'm not sure if that's what your viewer is referring to, but when somebody has bad arthritis in their joint and they've failed the non-operative treatments that Dr. Grothe and her partners would put them through, and they've reached the point where they need surgery, then we can put an artificial surface on the end of the thigh bone and made of metal, and an artificial surface on top of the tibia made of metal with a plastic liner. So you get a synthetic joint in a sense, and there's no nerve endings there, so the pain would be gone. The body still makes lubricating fluid that keeps it nice and smooth and contributes to a nicely functioning joint. So that's synthetic. I'm not sure if that's exactly what the reader had in mind.
Yes, I thought all knee replacements were synthetic, so
Yes.
that's why I wasn't sure either if that's what she meant or not. Thank you very much. Dr. Schnell, here's a question for you. This is from Dave in Duluth. When I wake up in the morning and when I sit too long, my feet tingle and get red up into my calves. Do you know what that is?
Yeah, so it could be a couple different things that I'm kind of thinking about. Just because of the redness, I'm thinking some type of constricted blood flow, and you guys may comment on this as well, higher up. And then same thing with the numbness and tingling, it might be some type of impingement on the nerves in the back of the legs. So I guess I'll let the others kind of comment on further up in the extremities.
Any additional comments?
Yeah, I think whenever there's tingling and numbness in the lower extremities, we look at where the nerves course. So sometimes it can be coming from the back, so that's an area that we evaluate from the knee or higher up. And so I think whenever there's nerve type symptoms and we don't see anything local in the foot or ankle, it's always important to evaluate higher in that nerve course.
I have a question for you, Dr. Grothe. This is from Clayton in Barnum. How can you treat knee and hip pain without opioids?
Great question. So actually there are a lot of different ways. We'll start, for instance, knee arthritis, for example. So I think most importantly, we treat, hip and knee pain, we'll say in the instance of arthritis, in the context of the patient. So it's really important to understand what their lifestyle level of activity is. And we start with non-surgical management, which can include lifestyle modifications, optimization of a healthy weight, and we consider various injection treatments such as corticosteroid injections, viscosupplementation, which are lubrication injections, bracing, as well as physical therapy, where we can really focus on core, glutes, external rotators, and really try to improve overall function, dynamic gait patterns, and ultimately try to get the patient back to doing what they enjoy. And so there are a lot of options for both hip and knee pain, particularly hip and knee arthritis, that we can treat without opioids.
That's excellent because we know that opioids are not effective long-term
Absolutely.
for chronic pain and can cause lots of difficult side effects and problems. Dr. Edgerton, this question comes from Nick in Two Harbors. And he says, after shots, this is his question, for bone spurs in the knee, what's the next step for treatment if pain persists? And some of that you covered a little bit. So I'm thinking, when should I come see you to talk about knee surgery?
I think the things that Dr. Grothe has outlined are very important. We should always try to maximize the non-operative treatment for instance, knee arthritis or bone spurs. And so it includes weight loss, it includes strengthening and physical therapy, injections to a certain extent, bracing, and then the patient gets to a fork in the road, so to speak, where they have to decide, can they tolerate the symptoms that they have, or is their pain at a point where it's interfering with their quality of life to an extent that they're willing to undergo surgical treatment and accept the risks of that, because there's no surgical treatment that doesn't have some degree of significant risk. So, and that risk will be determined by the patient's general health and medical conditions, but even a healthy patient has risk with surgery and can always be made worse with surgery. So they have to make that decision based on their symptoms. The number one reason that we do joint replacement surgery is for pain. So that's a very subjective thing. It's the patient's pain that they have to use as their guide for when they're ready for an operation.
And fortunately, the significant risks are rare, but you just have to be aware that they are a potential.
Correct. With all the things that we do now to try to optimize the whole process, risks are very small, but if they do happen, they can be significant.
Okay, thank you. Dr. Schnell, this question is from John in Duluth, and it's about surgery on the foot. He says, I've developed unilateral flat foot. Are there any surgical interventions for this?
Yep, absolutely. So a couple of conservative treatment options in general. We kind of talked about orthotics. A lot of people that come in that need orthotics that have flat feet need custom-made orthotics, just because their traditional ones aren't going to work great for them. They have a custom foot, so we need custom orthotics made specifically for their foot. The other thing that we do a lot of is different types of bracing options for conservative treatments. Once they've kind of gone through those and they can no longer again stand, we talk about pain for the main source of why we do surgical intervention. There's a lot of different types of flat foot surgeries that can be done, but most of them usually tend to be in older patients. There are a lot of different types of fusions to correct kind of the alignment of the foot, and usually it's fusion surgeries. And usually, like I said, it depends on an individual basis. And sometimes they'll end up getting MRIs beforehand to assess different tendons and that sort of stuff as well. So it's really a really complex surgery. It's probably one of the most complex things that we deal with as foot and ankle surgeons is reconstructive surgery for flat feet. So it's a very stepwise approach, and you need to have the right workup for it as well.
What kind of recovery period would a person with that kind of surgery expect to have?
Yep, so you're pretty much staying off your foot entirely for at least 2 months. Usually it's a minimum of 6 weeks. And then they start weight bearing as tolerated just in a walking boot after that for at least another month if things go well.
Okay.
Yeah.
Thank you very much. Dr. Grothe, this question is from John in Duluth, and he's wondering about after a knee injury, would a chiropractor be helpful after a knee? Now, I realize that none of you are chiropractors, so this may be a question that you aren't able to address, but what would your thought be?
Well, I think in medicine we have a team approach to medicine, and so I think there are various ways at which we can treat a condition. And so I think the most important part of that would be what's the diagnosis and what are we treating? And I think there are many ways that we can treat. So I think there definitely is a role. I think it just isolating the diagnosis and ensuring that we work that up appropriately is the most important thing.
Thank you. Dr. Edgerton, is kneeling bad for a person who's had a knee replacement?
That's a very interesting question. I get that almost every day from patients. Because when we do a knee replacement, as I mentioned earlier, we're replacing the diseased surface of the joint with artificial parts. So I don't have the knee cap on here, but the kneecap sits in the front of the knee. It's a bone within the quadriceps muscle. And the undersurface of the kneecap is actually replaced often with a plastic surface. So when you kneel, effectively you're putting weight on the kneecap and the plastic surface underneath it. Your body weight is going on that. And I think there's probably, there's two schools of thought. Some surgeons tell patients never to kneel on the knee because they're concerned about damage to the plastic component. My personal feeling is that if patients can tolerate kneeling and they can cushion the front of the knee and perhaps bring the weight a little further down the leg, like just below the kneecap, then I think it's okay. Most people who end up with knee replacements are not doing a lot of kneeling to begin with, so it doesn't usually become a very big issue.
Oh, good. When I think about people who like to garden would kneel, but they could get those really low seats that you can use for gardening and that type of thing.
Low chairs, kneeling pads are made for gardening. Some people wear athletic type pads like you'd use in volleyball to cushion, and I think it's fine. We want to keep people active with these operations and not give up any more than we have to.
Right, that's why we do them.
Yes.
All right. Dr. Schnell, this is a question from John in Duluth, and he says, what causes foot neuropathy besides diabetes, and how do you treat it?
Yeah, so there's a lot of different things that can cause neuropathy. We kind of talked about before a little bit, kind of talking to this too. Sometimes you have the pinched nerves higher up that can cause it. So a lot of people come in with neuropathy, and that is the first sign that they would come in with and get diagnosed with diabetes for that. So that's probably the most common one. Other things that we do look at is any different type of nerve entrapments, and there's a whole plethora of other stuff that can kind of affect your nerves in the body. Usually I just tell people for neuropathy stuff, basically you want to be checking your foot daily. So basically before you get out of bed in the morning, when you get out of the shower, whatever it is, make sure you're checking your feet. Your feet are more susceptible to getting different types of wounds that you wouldn't have noticed otherwise, and can get infected and all that sort of stuff. So I always tell people make sure you're doing your daily foot checks if you do have any component of neuropathy as well.
Okay, thank you. We'll just go right to Dr. Grothe. I have a couple of questions here, Dr. Grothe, and I'm thinking, well, I'll throw them both out there and see which one you want to address, or maybe both of them.
Absolutely.
Jason from Evelyn says, any side effects from these supplements? And one is osteobioflex and the other is glucosamine. He's talking about side effects. And Lori in Iron River wants to know what causes heavy leg sensation.
So first of all, to address the first question, so I think side effects, I think most of those supplements are really looking at glucosamine chondroitin.
Yep.
And so those are generally relatively safe supplements. And often what we recommend with those, so first of all, side effects, and then just general recommendations with those is everybody's body is different. And so most people can tolerate them pretty well. Some people may get an upset stomach depending on what other components are in that supplement. But generally, you know, if it's well tolerated, I often recommend people try them for approximately 3 months and see what response you get, and if they don't work, because the reviews are really, the research and the studies are really mixed on glucosamine chondroitin. So I would say try it for 3 months, assess your response, and then make a decision from there.
Thank you. And then heavy leg sensation? Anybody?
It's hard. That's a very general term.
It is.
I would be thinking about things like nerve issues, perhaps even in the spine, where you can get constriction of the spinal nerves. It can cause the legs to feel heavy or numb or weak, or some vascular problem that's decreasing the blood flow to the limb can cause weakness. But there's probably other things such as metabolic problems and so forth.
It's one of those things that the doctor wants to ask you a lot more questions.
Correct.
Absolutely. I
Before they can answer that
need
one.
to find out a lot more information. When did it start?
Yeah.
How long it's been going on?
So, Dr. Schnell, Jean in Superior says, my toe next to my pinky toe, so I think that would be the fourth toe, will start to hurt very badly to the point that I can't walk. What are the causes of this?
Yeah, so it could be a couple of different things. Without the full exam in front of me, I'm not really, quite sure. I'll just kind of talk about a most common thing that we see a lot of times is, different hammer toes and different types of hammer toes. So she could have some hammering going on in the toe. So basically, let's kind of show you exactly what that is. So here's the fourth toe here. Hammer toe can either be, I'll just kind of show you on this one, but it can be curling under at the end. A lot of times it's coming up in the middle, and it rubs on shoes, and that can be really bothersome. Another thing that I kind of have in my differential, just kind of based on that, some people end up getting, we kind of had talked about this earlier, some neuroma type sensations, and that's Morton's neuroma is most commonly found in this inner space here. It's when these two different bones, the metatarsals, come really close together, and they actually pinch the nerve that's in there, and you get a lot of shooting sensation or pain in this area as well. So that's kind of another thing that I'm thinking about as well.
Thank you. Dr. Edgerton, I have a couple of questions for you. One is from John in Ashland, Wisconsin, and he wants to know what is a bone spur. And then one is from Jeff in Duluth, and I know the answer to this, but of course you're the expert. Are there any exercises I can do pre-surgery to ease the recovery of an upcoming hip replacement surgery?
Sure. So a bone spur is a pretty generic term. I don't have an actual native knee joint to show you here, but when you get arthritis in a joint, along the edges of the joint, bone spurs form, I think, as a result of the inflammation that's occurring in the joint. Calcium is deposited along the edge of the joint, and on x-ray you'll see these spur-like formations. So bone spurs are really a reflection that the joint is arthritic. It isn't usually that the bone spur causes the pain. The bone spur is more a sign that the joint has arthritis, which means the cartilage surface on the joint has worn off, kind of like getting a bald tire on a car. As far as preparation for surgery goes, we're big believers in our program that the more you practice your exercises ahead of time, the easier they are to do after surgery. So we give all of our patients a book that has the exercises in it that they can practice ahead of time. With the knee, for instance, it's range of motion, getting full straightening and full bending. For the hip, I think strengthening all of the muscles around the hip girdle is important, and there are isometric exercises that you can do. A physical therapist in your community can outline those for you, or your doctor can provide them prior to surgery to dovetail into the things you'll be doing after, and it's extremely important.
And you have what you call joint camp to teach people these exercises and what they're supposed to do so they get the most out of their surgery, correct?
Right. We really believe in a group learning process for post-operative therapy. So we start ahead of time with a full guide to joint replacement exercise. Patients practice those ahead of time for the weeks before surgery. The day after surgery, we get them together with a therapist in a group setting, and everybody goes through them, including the patient's loved one, whether it's their spouse or friend or sibling who's going to be serving as their recovery coach or their support person. So, yes.
Thank you. Dr. Grothe. Chuck in Duluth and Rosalie in Gilbert have questions that are a little bit related, but we'll see what you think. Chuck is asking, what causes leg twitching at night and how can you treat it? And Rosalie's wondering about why after going to bed does she get charley horses in her legs? So leg twitching and charley horses at night.
Those are great questions. So those are questions I get pretty frequently. And, you know, just to talk about the overall general term of cramping, essentially. And so it can be caused, so I guess ultimately we don't know the true underlying cause of cramping. It's something that's not very well understood. A couple of ways that we start working that up, we consider making sure that you're well hydrated, that you've got appropriate balance of electrolytes. That's often where we start with the workup. But it's actually not very well understood. There are a lot of different things that we can try to start treating. You know, some of it includes exercise, various massage, maintaining level of activity and hydration. But it's something that we see very frequently and don't always have a good answer for.
Thank you. Dr. Schnell. Lee in Coleraine says, I have swelling by my Achilles and it is starting on my opposite foot too. I was told I have tendinitis. What can I do for this?
Yeah, absolutely. I'll just kind of grab my model out again here and we'll kind of talk about it. So the specific area that we're talking about is the back of the calcaneus. This is the heel bone here. The Achilles tendon, actually, you can see it's labeled on here, the insertion of the Achilles tendon comes down and inserts right in through here. So the tendinitis he's talking about, the tendon specifically, is the Achilles tendon that inserts here. A lot of times people also have a component of some type of bone spur. We kind of talked about these already in the back and through here as well. That can be contributing to this. As far as conservative treatment options, we talk about offloading, which you can do in just a walking boot, which is pretty much provides a rocker, so you're not doing a whole lot of push off. And work of the Achilles tendon when you're walking. That's one option. Another option is to do different physical therapy modalities, which is, again, great idea to bring that team approach into things. They can do different type of stretching exercises. They also can do iontophoresis, and you're probably familiar with that, where they're able to do a steroid kind of right into the area to kind of get things to calm down. Also over-the-counter ibuprofen and that sort of stuff helps as well. Surgically, once we've tried all those different types of options and nothing really seems to be working, usually the surgery involves taking off the bone spur if that is present, kind of cleaning up the tendon and then reattaching the tendon back down so it reattaches to a smooth area, and you're able to clean up the bad portion of the tendon as well as part of that surgery.
Is it beneficial to soak your feet in Epsom salt when they're swollen? Myron in Grand Rapids asks.
I guess I've tried that a few times personally, and it has worked for me. I don't always tell my patients, different things. Again, we had talked about that neuropathy component before, so if you do have any type of decreased sensation, I always tell people make sure that you're, double checking the temperature of the water before you actually dip your feet in there and enjoy a nice soak.
All right, thank you. Now, this next disorder is one that I'm not very familiar with, so I'm not sure which one of you would be the most common person to be asked a question about Morton's neuroma.
Go ahead.
Well, I'll ask the questions.
Yeah, go ahead.
Would it be?
Tag team.
You tag team? Okay. Here are the two questions. Barb in Duluth says, what is the efficacy of alcohol instead of surgery to treat Morton's neuroma? And John in Grand Rapids says, what is the treatment for Morton's neuroma?
So I guess I can talk about basics of neuroma. We talked about this before, but again, that's kind of a pinched nerve right in this area and through here. Conservative treatment options, they already kind of mentioned and talked about. There's different types of injections that you can do, and you can kind of comment on using the ultrasound for that maybe as well. But there's either different types of sclerosing injections, which would be with the alcohol, and the idea behind that is to try to kill the nerve basically, or corticosteroid injections, and that would be just to provide more of a relief type thing. There's other options, surgically to remove it, but you're going to end up with kind of some numbness in between these two toes, but I'll let you kind of comment maybe on the injection part of it.
Yeah, absolutely. We do use ultrasound guidance to inject Morton's neuromas. I would say more commonly or more frequently, we do corticosteroid injections for pain relief. Those tend to work pretty well. We do alcohol injections as well. But what we find is, so first of all, the studies are mixed on those, and what we find is about half the patients get improvement with that. And when they don't work, we do find that it is harder to treat surgically when they have been injected multiple times with alcohol injections.
Well, thank you very much. I had several more interesting questions I wanted to ask, but our time is up. I want to thank our panelists, Dr. Brad Edgerton, Dr. Heather Grothe, and Dr. Katherine Schnell, and our medical student phone volunteers, Nissa Grina, Rachel Hoyer, and Brandy Bolig. Please join Dr. Paula Tremulin next week for a program on upper GI problems when her panelists will be Dr. John Reich, Dr. Stephen Vopat, and Dr. Derek Williams. Thank you for watching, and good night.